Hi everyone, thank you for joining us tonight. I'm Rachel Dornbos with Prima Eye Group, and we are excited to host this webinar with Diopsys and Dr. Nathan Lighthizer. Dr. Lighthizer will review the science of electrophysiology and how it provides valuable information to make more informed treatment decisions. Prima is privileged to provide tonight's program, the Emergence of Electrophysiology into Clinical Practice. The program will run about 45 minutes, followed by a question and answer session at the end. We are recording this program to be placed on the Member Resources section of our Prima website for any of the Prima members in attendance tonight. And thank you for your participation, and at this time, I will hand the program over to Dr. Lighthizer.
Okay, thank you, Rachel, for the introduction, and welcome to everybody for this evening. Again, my name is Dr. Nathan Lighthizer. I am at the Oklahoma College of Optometry in Tahlequah, Oklahoma, and I'm in charge, or the chief of our electrophysiology clinic, which is the topic of tonight, VEP and ERG, an emergence of electrophysiology into clinical practice. You know, it's been exciting over the past 4 or 5 years as electrophysiology has really transformed from a academic setting, research-based setting. Almost was unheard of to have electrophysiology in private practice or clinical practice, and that has really changed over the course of the last 4 or 5 years. There are conditions that I never did electrophysiology at all before that have now, we send them to our clinic and run most of our glaucoma patients or most of our plaquenil patients through our electrophysiology clinic where they get multiple tests. So it's really changed and transformed how we use these tests and utilize these tests over the past couple of years. So again, here are my disclosures. I am not an employee of Diopsys. I am not a consultant for Diopsys. I am paid an honorarium fee for my talks for them. Simply put, I believe very, very strongly in this product. And again, it's been a wonderful, wonderful piece of equipment that we have had over the past few years. So here's our outline. We're going to spend about 15 minutes on VEP. We're going to spend about 10 minutes on the ERG, and then we're going to go through 3 or 4 clinical cases to drive home how you utilize this, what you use it for, and just how to interpret the reports and how to do the testing. So when I lecture live, I always give the audience interactive remotes. I think it's a great way to poll the audience without having to ask you guys to raise your hands, and it's a really powerful tool to gauge what your colleagues are thinking. And the first question I always ask is, which of the following is an indication to perform a VEP? And I always add to the question, based on your training in optometry school or residency or whatever you were trained, what was the one reason why you thought to do a VEP? And the answer I always get, it's usually 60 to 70%, is unexplained vision loss. We always think of a visual evoked potential, VEP or VER, as an unexplained vision loss tool that if a patient was maybe 20/70 or 20/80, and yet you look at their eye and boy, they should be seeing 20/20 or better, that's probably unexplained vision loss, and that's absolutely true. It's the answer that I would have responded with 4 or 5 years ago. The answer to the question is now all of these. We're going to highlight glaucoma in the next 45 minutes. We send most of our glaucoma patients, or a great big chunk of our glaucoma patients, through our electrophysiology clinic, where they get OCTs, which are a wonderful tool to look at structure, and they're now getting VEPs and pattern ERGs to look at function as well. So all of these can be utilized, and you're going to see that in the cases as we go forward here. When it comes to the VEP and VER, it measures the entire visual pathway. The VEP by itself is not specific for anything, meaning I can't show you a VEP that has an abnormality and you know where the problem is, because it measures the entire visual pathway. So a problem in the VEP could be in any part of the visual pathway. Where it proves so beneficial is when you use it with your fundus exam and an OCT and maybe an MRI or a visual field, and it helps to pinpoint. It's a great another piece of the data to help figure out what's going on in that patient. There's 3 electrodes. You put them on the forehead, the temple, the back of the head as well. And these electrodes stick right on there with a little bit of paste, and they will measure the electricity that we're measuring. That comes in a waveform. And this is the VEP waveform. And I always spend, a minute or two looking at a VEP and the waveform, because a lot of docs, myself included, we're used to pictures. We're very comfortable with fundus photos, OCT is basically a specialized picture, and then you throw up a VEP waveform, and there are lines going everywhere, and we're not used to this, and it may make us a little bit uncomfortable. When it comes to the VEP waveform, you can see my cursor here. There is a dip down, there is a dip up, or it goes up, and then it dips down again. This is the waveform that I'm circling right here. That is the most important part. Everything else back on the end part there is complete junk. You don't have to worry about that at all. There are two parts to the VEP waveform. The first one is the amplitude. The amplitude roughly correlates to the amount of signal going back through the visual pathway. The amplitude is important, but it's not as important as this one right here, the latency. How long does it take to get to that top peak or positive peak? On average, in normals, it's about 100 milliseconds. The normal range, or the green range, we're all used to OCTs, green as being relatively normal. The normal range is 95 to 125 milliseconds. That's your normal range. To give you one number, they call it the P100. 100 milliseconds, or a tenth of a second, for that signal to start at the front of the eye and register at V1, or the visual cortex. Amplitude is important, but it's not as important as the latency. How long does that signal take? Of note, it's not a speed. If it was a speed, then the faster the better. The bigger the number, the better. This is how long does it take. It's a time. So 100 milliseconds is good. As you get to 125, 130, 135, 140, that signal is being delayed from possible glaucoma, optic neuritis, things like that, and that's not as good then. So you want a smaller number when it comes to the latency. Here is... When we go to the VEP, why the VEP? And specifically, why the VEP when it comes to glaucoma? We've got so many tests in glaucoma. Optic nerve head OCTs, we've got the ganglion cell OCT, visual field, gonioscopy, Goldman, pachymetry. We've got all these tests. Why do we need the VEP? Well, when you look at the visual field in the OCT, a visual field looks at function. But it is subjective. It relies on the patient. And as you guys know, patients, are they great at visual fields all the time? It's really a big weakness of the visual field. The OCT certainly is better. The OCT is objective. It does not overly rely on the patient. It looks at structure. But don't we wish we had something that would combine both of those? Something that was objective, that looks at function. Now we have that with the VEP and the pattern ERG, and that's exciting. It kind of fills that niche right in between the visual field and the OCT. So when it comes to glaucoma, is this new? I graduated 6, 7, 8 years ago from optometry school, and I don't remember a VEP being talked about in glaucoma. So is this new? Well, if you go onto the internet tonight and do some research onto PubMed and type in VEP and glaucoma, you're going to get dozens upon dozens upon dozens of studies that are dated from the 90s, the 80s, the 70s, saying that the VEP in glaucoma is well-defined science. So why haven't I been using a VEP and ERG for glaucoma until the past 2 or 3 years? We didn't have the technology in terms of a smaller unit that wasn't as expensive. It's more patient-friendly, more doctor-friendly, and more staff-friendly. Diopsys and other companies have really done a wonderful, wonderful job of introducing this technology and taking it from the research lab, from the academic world, into private practice. Here's a study again. It goes back to that latency. It's not necessarily the amplitude. Amplitude's important, but that latency, when that increases, when that's delayed, it's significantly correlated with the severity and location of visual field defects, the degree of cupping and pallor of the optic disc, all things that you guys look at in glaucoma. Here was the exciting one. And when it comes to glaucoma, we've got the visual field, historically the standard test when it comes to glaucoma. And the biggest problem with the visual field is it's not that sensitive in detecting early glaucoma. We all know, and I'm sure when I ask this question, most doctors get this question right. What percentage of ganglion cells are dead by the time your glaucoma patient has an early visual field defect? And the answer is anywhere from 30 to 70%, depending on the study that you read. Let's call it right in the middle. 50% of ganglion cells are dead by the time your patient has an early glaucomatous visual field defect. The visual fields are just not that sensitive in detecting early glaucoma. OCT is better. OCT looks at structure, and it can tell you when 10%, 20%, 30% of ganglion cells are dead. But we've never had a test that was able to detect when cells were struggling, or they were wounded, or they were suffering, or they were dysfunctional, but now we do. This is a study of 2009 looking at those ganglion cells that are alive, suffering, and dead. And those suffering ganglion cells and their nerve fiber layer in glaucoma, when they lowered the stressor, how do we lower the stressor in glaucoma? You guys all know that there's really only one way. We lower the IOP. When they lowered the IOP, and then they were able to detect, watch what happened to that suffering ganglion cell. It improved. It was alive. It was doing much better, and they could detect that on the VEP and pattern ERG. We now have a test that will tell you when cells are dysfunctional, struggling, suffering. They're not dead yet, and hence we have time to save them by lowering the stressor. So VEP does a great job at that. It does it through a protocol with Diopsys. The LX protocol, it's a standard protocol, and it looks at high contrast and low contrast. I want you to remember that high contrast corresponds to parvo, and low contrast corresponds to magno. Now, magno is more important in terms of early glaucoma. We have more parvo compared to magno. And again, stay with me. I'm really diving into retinal anatomy here for about 30 seconds. More parvo compared to magno. It's about 80 to 20. Well, glaucoma takes out both at about the same rate. So if you lose 5 parvo and 5 magno, which one's hit to a higher percentage? Well, it's certainly the magno, 5 out of 20 compared to 5 out of 80. And that's why they think the earliest changes in glaucoma happen to the magnocellular pathway. So if we can detect changes in the magnocellular pathway early, we can detect glaucoma earlier and earlier and earlier. So that's what this protocol does. Is it has high contrast, which is parvo, and low contrast, the most important low contrast, which is magno. So we look at the low contrast latency. There's the machine right there. Again, doesn't take up half the room or the entire room. It's about 2.5 by 2.5. It doesn't really take up any more room than the OCT. It's just a little taller than the OCT. Patient sits 1 meter away. They have their best correction in place. And again, an electrode on the forehead, on the temple, on the back of the head as well. You can see a staff member running the test on the patient. Test time is 38 seconds in each eye. 38 seconds in the right eye, 38 seconds in the left eye. It's actually 8 seconds of a warm-up test. They're sitting there, they're covering their left eye, looking at the checkerboards, they're going back and forth and back and forth. 8 seconds of a warm-up test. Nothing is being measured. And then 15 seconds at high contrast. That's parvo, remember. And 15 seconds at low contrast. That's the magno. So 38 seconds in the right eye, 38 seconds in the left eye. So test time is under 1 minute in each eye. Setup takes actually longer than the test. Setup's going to take you 6 to 8 minutes by the time you clean the areas, put the electrodes on, get them hooked up. So setup is probably 6 to 8 minutes, and then actual test time is under a minute in each eye. From when I walk into the room with the patient, from when until I walk out of the room with the patient, on average, I've timed myself many times. It's right at 10 minutes from when you walk in the room to when you walk out of the room. Here's the printout. The first thing I notice is you got colors. I've got 3 VEPs in my office. I only use one of them because there's a wonderful normative database, and we all like colors. Don't lie to yourself. I'm not going to, I like colors as well. Green, good. Yellow, borderline. Red, bad. So let's go through this printout, this Diopsys VEP report. First thing you're going to see, there's all the demographics at the top. You fill that out, or that machine fills it out for you. You have a signal quality. Green, yellow, and red. Obviously, you want green. This is measuring how well did you clean the skin and how well did you connect the electrodes to the skin. Doesn't mean they're in the right spot. It just means, do you have good electrode contact with the skin? Then you go down to the waveforms. And notice there's the right eye on the left side and the left eye over here. You're going to see 2 lines. The dark line is high contrast and the light line is low contrast. Remember, we're doing 2 tests in each eye. This is the raw data, the raw waveform, and this is why we went through that VEP waveform just a few minutes ago. And you can see this dip down, the dip up, and the dip down again. The rest of this all over here is complete junk. We're just looking at that VEP waveform there. This looks all good in both eyes, and that throws it into a table. And we're going to have 4 bars in each table: high contrast amplitude, low contrast amplitude, high contrast latency, and low contrast latency. Again, that low contrast or magnocellular latency is the most important. It's going to have it in a normative database, green, yellow, red, and you can see all of this is very much in the normal range. Colors can fool you. We've been fooled on the OCT before where it says it's in the green, but maybe it's not necessarily normal. It says it's in the red and it's not necessarily abnormal. So you still have to look at the numbers. Again, remember 95 to 125 milliseconds. That's the normal range when it comes to the VEP latency, and the quicker the better. I like it right at 100 to 105 milliseconds. That's wonderful there. Then it throws into a table. Again, we've got right eye directly comparing to the left eye, because we've probably seen it with the OCT as well, where you've got both of them in the green, but yet one eye may be 102 on the OCT, and the other one may be at 81 on the OCT. They're both in the green, but there's some asymmetry there. This instrument will tell you that. It will do a little analysis for you that it will look at the latency, and if there's more than a 10 to 12 millisecond difference between right eye and left eye, it will flag that for you and say, hey, doctor, pay attention to this. Both may be in the green, but they may not necessarily be normal. So it's going to give you those numbers, look at those numbers, and see where they're at. You can see this patient for the low contrast latencies at 124 and 117, both green, both in the normal range. Is that normal or abnormal? Well, it depends on the clinical picture. It's on the low end of normal, but it may be normal for this patient. And then you sign it at the bottom. Again, here's a very normal VEP. You look at it, you can see the signal quality at the top is in the green. We've got our nice VEP waveforms, and we're green across the board with low contrast latencies about 114 and 112 here. Here's another one showing some abnormal findings in the right eye and slightly abnormal findings or borderline normal findings in the left eye. Even though they're all green, you again look at the numbers. The low contrast latency, we're at 128 in the right and 124 in the left eye. So even though it looks like right eye abnormal, left eye normal, you still got to look at the numbers in this printout. Here's what I was talking about earlier. Again, looking at everything, we're green, green, green across the board. But in the right eye, we're low contrast latencies 109, left eye is 122. Notice there's a box right next to that. It's highlighted in red. What's the difference between the two? Well, it's 12.7 milliseconds. And it goes, hey, doc, pay attention to this. They're both in the green. They're both in the normal range. But I want you to pay attention to the asymmetry between the two eyes. So it will flag that for you and do a little bit of analysis and tell you, hey, there's a significant difference there. So when it comes to the VEP, again, it objectively measures the visual pathway from front of the eye all the way back to the occipital cortex. Most common reasons we do the VEP, glaucoma is the biggest one, unexplained vision loss, MS or optic neuritis, which we'll see in the cases here in just a few minutes. We get a lot of referrals from neurologists and their MS patients to do a baseline VEP and then do VEPs every so often to see, are there any conduction problems? That visual signal should go back pretty quickly, 100 to 110 milliseconds. Well, if they're developing lesions in their brain, white matter disease, that signal doesn't go back as quickly, and you can follow MS patients over time. So glaucoma, MS optic neuritis, unexplained vision loss. How often do you guys bring patients back to repeat a visual field? We do it all the time in glaucoma. I encourage you, bring them back to repeat a visual field, but do that VEP and ERG as well to really get some objective data. So when it comes to the next test, the pattern ERG, it's the sister test to the VEP. It's all on the same instrument, where the VEP objectively measures the function of the entire visual pathway. This objectively measures the function of the ganglion cells or the retinal function. It's looking at those mid-retinal or inner retinal layers. How are they functioning? It's basically the equivalent or the corollary of that ganglion cell analysis on your OCT. You guys probably have ganglion cell analysis on your OCT. It's looking at the structure of the ganglion cells. How is that looking? This is looking at the function of the ganglion cells. Are they functional or are they dysfunctional? It does it through two protocols. It does it through concentric stimulus fields and contrast sensitivity. The concentric stimulus fields, concentric meaning circles. Patient is looking at a computer screen just like the VEP, and they're going to look at a big circle. And that's going to go back and forth and back and forth. The test time is 25 seconds, and it's going to generate a waveform. That is the pattern ERG waveform there. And then the next test is going to be a 16-degree circle. Notice it's a smaller circle, and therefore it's going to generate a smaller waveform. Again, notice the pattern ERG waveform. I call it the humptitude. There's 3 humps there as you go along. The concentric circles, 24-degree and 16-degree, are good for any maculopathy that presents in a specific pattern, whether it's plaquenil toxicity, macular degeneration, diabetic macular edema. The biggest two that why we do this protocol is plaquenil toxicity and macular degeneration. That's your circles. The other protocol is going to pop up right now is contrast sensitivity, high contrast and low contrast. Sounds very similar to the VEP. The high contrast is 85%. It's going to go back and forth and generate, notice our pattern ERG waveform. Looks very, very similar. It's then going to fade to low contrast. That's 15% contrast, and you're going to see another waveform that obviously is going to not be as robust as the high contrast. The high contrast generates a very robust waveform. The low contrast, not as much there. So when do we use high contrast, low contrast? Well, with the VEP, which was high contrast, Parvo, low contrast, Magno, we use that in glaucoma. We emphasize that in glaucoma. Same thing for this protocol. The contrast sensitivity pattern ERG is for glaucoma. High contrast, low contrast. Your generalized retinopathies, you could detect just generalized dysfunction in that macular area with this protocol as well. Here's kind of the stats behind each of them. The test takes 50 seconds. There is no warm-up test with the pattern ERG. Remember with the VEP, it was 38 seconds, but there was an 8-second warm-up. There is no warm-up with the pattern ERG. You do 25 seconds with the big circle, and then 25 seconds with the small circle, or high contrast and low contrast, right eye and then left eye. So again, under 1 minute of test time for this pattern ERG. They sit a little bit closer to the screen, so I would add their best correction plus 150 on top of that. Concentric stimulus fields. Remember the circles, plaquenil, AMD, 2 biggest ones. Contrast sensitivity, high contrast and low contrast, again sitting 24 inches away. Best correction plus 150. We've got the right eye and left eye. Again, test time is exactly the same, 50 seconds right eye and 50 seconds in the left eye. Study out of Baskin Palmer looking at the pattern ERG and going back to that principle of how soon can we detect changes in glaucoma. We know glaucoma is a neurologic disease. And the sooner that you jump on neurologic disease, the better. I have a family history. I was born and raised in North Dakota. I was born and raised there, first 23 years of my life. And I have an extensive family history of multiple sclerosis. I have 6 family members on my mom's side with multiple sclerosis. One of my aunts in the past 5 to 10 years was diagnosed with multiple sclerosis by her optometrist. She had an optic neuritis. And the neurologist told her, "You're going to do better because you were diagnosed earlier." And he said that's very true for most neurologic disease, and I think glaucoma is no exception. Well, remember, the visual field is not that great in detecting early glaucoma. 50% of ganglion cells are gone. They're dead already. OCT is better, as you can see from this video, but it looks at structure, alive or dead. It does not look at dysfunction. That's what we've got the pattern ERG and the VEP for. It looks at function or dysfunction, and it can tell you, boy, these cells are dysfunctional. They're not dead, but they're dysfunctional, and if we can lower the stressor, like in glaucoma, lowering the IOP, then patients tend to do better, and we're going to see that in the studies here, or excuse me, in the cases here in just a few minutes. Again, what goes back to this study, and we already talked about that. The ultimate conclusion was patients who are glaucoma suspects, those ones where you're just right on the fence, could go either way. The pattern ERG signal anticipated an equivalent loss of OCT signal by several years, as many as 8 years in some patients. That's an exciting study. I was up at the Academy meeting in Seattle a year and a half ago, and I was at a glaucoma talk, and these optometrists and ophthalmologists, it was a symposium, were highlighting how the pattern ERG is really going to be the test of the future to detect glaucoma at its soonest point there. Here are the indications. Again, we talked about them: glaucoma, plaquenil, AMD. Those are really the 3 biggest reasons why we're doing the pattern ERG. You can see the electrodes there. One goes on the forehead, and then they have one right on the lower lid there, right eye and left eye. Test time 50 seconds in both eyes. I like the lid sensor. I've used all of these. This is one of my other lid sensors, and it's a big old lid electrode. It's called the Berian Allen electrode. It's a wonderful electrode. It costs $1,100 per electrode. They are reusable, and they have good signal, but you get a lot of pushback with that electrode on the top left. Again, the Berian Allen electrode. Fortunately, with this system, you don't have to do that. You use that Diopsys lid electrode there. Those cost about $11 or $12 each. So there is about a $20 to $25 cost per patient for the electrodes. You will get reimbursed. In your reimbursement, you get that back, and we'll talk about that. But that lid electrode, I have no pushback at all. Again, runs about $11 to $12 per lid electrode. Here's the printout with the pattern ERG. And again, you're going to see that there's really three things that I look at. Number one, I call the humptitude. You should see nice, smooth 3 humps from each printout. Notice there's 2 in each eye. Right eye and left eye, you're going to have big circles and small circles, or you're going to have high contrast and low contrast, depending on which protocol you choose there. You want to see these 3 nice, robust humps here. They should be smooth. They should be relatively tall or robust, and that's what you want to see. That's number one. Number two, you look at the magnitude down here in this table. The magnitude should be 1.2 or higher, and the bigger the number, the better. I'd love to see 2.8, 1.7, 3.2, and 1. Those are great, wonderful results. Absolutely normal pattern ERG. So that's the second thing. And the third thing is the magnitude D. The magnitude D really represents how repeatable are the measurements. Are they in phase? If they're out of phase, when the top part of the hump is now lining up with the next bottom part, that's out of phase. So in an ideal world, every reading is right on top of the previous one, and that's completely in phase. In that scenario, the magnitude D would equal the magnitude. So I want the magnitude D to be as close as possible to the magnitude. In an ideal world, they're equal. The normal range is 70% or higher. So that's what when we look at when it comes to the pattern ERG printout. Look at the humptitude, the qualitative, what do the curves look like, or the waveforms. Look at the magnitude, and look at the magnitude D. Let's go through some cases. There's a normal one right here. Normal printout, and then look here at the abnormal one there. Obviously, the humptitude looks terrible. The numbers are reduced. Your magnitudes are between 0.7 and 0.8, drastically reduced. That's a severely abnormal pattern ERG. Case number one. Diving into the case, a 62-year-old white male was a glaucoma suspect for reasons that you'll see in just a few minutes. His pressures ran between 20 and 22. His pachymetry was relatively normal. Gonioscopy was non-contributory. You take a look at his optic nerves, right eye and left eye, and certainly you look at these, and the CD looks like to be about a 0.65, 0.7, 0.75 in the right eye. We called the right eye a 0.7. The left eye we called a 0.5. So there definitely was some CD asymmetry. But you take a look at the optic nerve head size, and boy, that right nerve sure looks bigger than the left nerve to me as well. So we've got some CD asymmetry there. You take a look at his visual fields. 24-2 visual fields. Left eye looks pretty good. Right eye doesn't look too bad. He had a couple of points in the superior paracentral area. These visual fields were pretty reliable, but they weren't the most repeatable. Those couple of points in the superior paracentral area tended to move around on that right eye. They tended to be there, but they tended to fluctuate and move around a little bit. So they were somewhat non-repeatable as it moved around there. So I always ask this question, based on the current understanding, you've seen this 62-year-old male, his pressures are 20 to 22, pachymetry is 545, you've seen his nerves and you've seen his visual fields. What would you do at this point? Or what would you call the patient? And I don't think there's any right or wrong answer here. But this is really where the clickers become fun, because you can have 20 or 30 or 40 or 200 doctors answering this question. Then it puts the results right there. I will tell you that for most audiences, when I present this case, about 80 to 85% call this patient a glaucoma suspect. They right in the middle, and I completely agree. About 10% call it glaucoma, and about 5% say it's no glaucoma. So the vast majority, 75 to 85%, call the patient a glaucoma suspect. Let's continue to follow closely. I agree 100%. Here's the OCT. You look at the patient's OCT, a couple of things that you see. When you look at the disc on this Zeiss Cirrus OCT, average disc is 1.76 millimeters squared. They're at 2.77 in the right and 2.23 in the left eye. Obviously, we have big discs here. So that could be responsible for our big cups. You see a lot of green, but it's a little bit thinner with some potential changes, right eye more than the left eye. Same question as before. We've added the OCT now. Did that change anything for you? Would you continue to call this patient a glaucoma, a patient start treatment, glaucoma suspect, or no glaucoma? And again, for the vast majority of the audience, it's really interesting. I asked you the question before the OCT and the same question after the OCT, and 75 to 85% still call this patient a glaucoma suspect. We're still right in the border. 62-year-old male, pressure's 21. You've seen his nerves, seen his field, seen his OCT. So we were right on the fence. And you may say, Dr. Nate, I would have diagnosed this patient with glaucoma, and I couldn't disagree with you. But patient was sitting in my chair, and he was very insistent that, boy, I do not want to start drops unless I absolutely have to. I don't like drops, and I'm not going to be good at putting them in my eye. Doctor, you better make sure I have glaucoma before you start me on eye drops. So we added one more test, the VEP. And you look at the VEP, and we highlighted in glaucoma, the most important reading is the low contrast latency. Magnocellular pathway is low contrast. Looking at that latency, and sure enough, we're at 137 in the right eye and 127 in the left eye. Well, this is really the test that was the straw that broke the camel's back. We were right on the fence tipping, is it not glaucoma? Is it glaucoma? We're right on the fence, and this test confirmed we've got some dysfunction in the magnocellular pathway, and based on this reading and the pattern ERG on the next slide, you can clearly see that on those low contrast pattern ERG, there is the humpitude doesn't look quite as good, the magnitudes are not quite as good. We have got some dysfunction in those ganglion cells as well. Based on these two tests, we diagnosed the patient with glaucoma. He felt comfortable being diagnosed with glaucoma, and we started him on treatment. Here's where it gets interesting and where it's really been exciting over the last couple of years. We put him on glaucoma therapy, on a prostaglandin. His pressure was between 20 and 22 pre-treatment. That went down to about 16 post-treatment. And we followed him in the months and year afterwards. And remember, this was his VEP. And you remember that study where they lowered the stressor and those ganglion cells were thriving. They were alive. Here was his VEP before treatment. We lowered his pressure by 5 or 6 points, and this was his VEP after treatment. And this is really cool. We've seen this in so many patients. Not all. I mean, I'm showing you a great case here. Does this happen in everyone? Absolutely not. But boy, it's been exciting to see this happen in a numerous patients where you lower their pressure and you can show, boy, look at your visual system is functioning better. His low contrast latency improved by 10 to 15 milliseconds in that right eye and a few milliseconds in that left eye, and he was just floored at this and goes, wow, that's awesome. I'm in the green now. What a powerful tool for the patient. So real quickly in the opposite scenario, are we overdiagnosing glaucoma? This was a 56-year-old Native American male, and he was referred in for his yearly glaucoma evaluation. His OCT, he'd been diagnosed 5 or 6 years ago. And you'll see why he was diagnosed in just a little bit. His pressures were again running 20, 22, 23 somewhere, and their pachymetry was 530, and he was on Combigan and Travatan. So 2 drops with 3 different medications, pretty heavily medicated. That was his nerves. Pretty similar picture to the last patient, just flipped the eyes a little bit. Left eye we called about a 0.65, big nerve. Right eye we called about a 0.45 or 0.5, not as big of a nerve. Here were his visual fields. Visual fields were done 3, 4, 5 times, about every year, and these are what his visual fields always looked at. His OCT was 82 in one eye and 80 in the other eye, right in the border between green and yellow. So I ask you this. In this 55-year-old male, or let's go before treatment. His pressures were, let's say they were 21. Pressures were 21. Pachymetry is 530. You looked at his nerves. You guys see these patients all the time. You look at his nerves, and that's what they are. You look at his visual fields, and that's what they are. OCT is 81 to 80. What would you have done at this point? Certainly maybe he's over-medicated and doesn't need to be on 3 medications, but I think a lot of us, and when I lecture live, a lot of docs say, I would have diagnosed him with glaucoma. Well, he came in for his yearly glaucoma, OCT, and now we had the VEP and the pattern ERG, and that was his VEP and pattern ERG. And you can clearly see a lot of green on the VEP. We have an intact functional visual pathway, and we have an intact functional ganglion cells. We have this now wonderful objective data that just said, boy, his visual system is functioning wonderfully. And we said, well, we've got some options now. It's not always easy to take patients off of glaucoma therapy, particularly when they've been on them for many, many years. He's been on them for almost 6 years. So we sat him down and said, do you want to take off all your drops? Should we stop the drops? Just stop you off 1 drop? Or should we keep you on both drops because you just want to keep on both drops? And he said, you know what, let's wipe the slate clean. I'll start over. And we told him, you can't go away. You can't leave for 10 years or for 5 years if we take you off the drops, because maybe he's in the green because his pressures were 12, and we take him off the drop and his pressure goes back to 21 and he goes into the red. So he agreed that, yep, I'll come back and in about 6 months we'll repeat the readings. His pressures went up to about 16, 17, 18, somewhere in there, and he remained in the green. His latency did go up a few points, but it still was in the green. We were happy with it at that point. So we have incorporated the VEP and ERG into our protocol. We do them about once a year, just like OCTs and visual field. Let's go off glaucoma for just a few seconds. Got a couple of cases. Your case number 2, 18-year-old female. Interesting patient, has a medical history very similar to my own, and the fact that she had a lot of family members, 5 of them, with multiple sclerosis. And she was concerned that she was going to develop what all of her other family members had been developing. 6 weeks before we saw her, she had developed blurry vision in the right eye. She said it wasn't bad, but I just started to notice, it's a little blurry in my right eye. And then she had a work-related accident. She had hot grease working at a fast food restaurant splash on the right side of her face and into her eye, and her world really was ending after that. She said, I've got severe headaches on the right side, I've got pain in my eyes, I've got pain on eye movements, and I can't see anything at all. She even mentioned double vision at some points of the exam as well. So she had a lot of complaints after this work-related accident, hot grease splattering into the eye. So she was very, very concerned. We saw her multiple times. Her vision in her right eye was usually 2100 to 2200, somewhere in there. Her left eye was completely normal. She did not have she didn't have any APD, so take note of that, but she did have significant pain on eye movements. There's her fundus. Back of the right eye there, artifact between the nerve and the macula looks overall pretty good. No signs of any optic nerve head swelling, although 2/3 of cases of optic neuritis are retrobulbar. Her macular OCT in the right, macular OCT in the left eye, and optic nerve head OCT right here, which all looks very, very good. Her OCTs are showing wonderful retinal structure, wonderful optic nerve head structure on the surface of the disc. So at this point, we had a decision to make. We've got this 18-year-old female with a very strong family history of multiple sclerosis. She's got blurry vision in one eye, pain in eye movements on that eye, and this strong family history. Is she developing what her family members have developed, the retrobulbar optic neuritis, even though she did not have an APD? So we strongly considered sending her for an MRI, but we have the VEP right down the hall, and I told my students and residents that were with me that day that if she has an optic neuritis going on that's decreasing her vision to 2100 to 2200, the VEP is absolutely going to be delayed. It's not going to be 100 milliseconds or 110. It's going to be 135, 140, 150 milliseconds. So the VEP is the test that's going to decide, is there actual structural change going on, or is she having some psychogenic vision loss? That was her VEP. And when I asked this question, it's always interesting. I was just in Orlando, Florida on Tuesday night presenting for a society there, and I asked this question. There was about 40 docs in the audience, and 65% said, I think it's optic neuritis. 35% said it's psychogenic vision loss. We did the VEP, and you look, and it's green, green, and green. And the VEP is so useful when you have one eye that's normal, left eye. We knew the left eye VEP was going to be great, so we have something to compare. we knew the left eye was going to be the baseline, looks great, and now you go over to the right eye and go, boy, those are very, very symmetrical. She does not have an optic neuritis going on here. She kind of had psyched herself out into blurry vision between her family history and the work-related accident there. So we educated her and talked with her and said, between your normal exam, normal OCT, but most importantly, you've got a normal VEP, you do not have an optic neuritis at this point based on our testing. It looks wonderful. And she just kind of melted in our chair and said, oh, I've been so worried. And her vision was back to 20/20 within a few weeks after that. She just needed a stress reliever, a little talking to and reassurance, and she did very, very well. I'm going to go through this case. I got one more case here I'm going to go through. Okay, case number 4. Last case before questions. 65-year-old female. About 3 or 4 minutes left. A patient that one of my colleagues here in Oklahoma saw emailed me the case, 65-year-old female that came in really for a couple of complaints. Number one, she said it's blurry in both eyes, left eye a little bit worse than the right, and also I can't seem to see as well out of my peripheral vision in that left eye. So I had 2 subjective complaints. He answered the first one with an updated refraction. She came in seeing 20/30 shaky in 20/25 and a little updated refraction, +5 hypero, poor dear there, and she's 20/25 plus. We answered the first subjective complaint. She had a family history. Excuse me, I take that back. She had a personal ocular history. She was a great historian. She's 65 years old, and she's told Dr. Ken, the doctor in Oklahoma here, one of my colleagues, she said, 58 years ago, I had an eye exam. And I remember about 4 different doctors looking at my eyes when I was 7 years old, 58 years ago, and they told me I had elevated optic nerves. They looked and looked and looked, and ultimately nothing came of it. They just told me, yeah, you've got elevated optic nerves, probably won't affect anything down the road. So factor that in to some degree as well. Front of the eye looked fine, back of the eye looked fine with some elevated optic nerves. There's her visual field. Give you a few seconds to take a look at the visual field. Again, got some visual field defects, temporal quadrant, a little bit worse than the nasal quadrant in both eyes, left eye, a little bit worse than the right eye. Macular OCTs in this high hypero, +5. Macular OCTs look pretty good. Optic nerve head OCTs. Couple things you look at. You look at the disc area. Again, 1.76 millimeters squared in the optic nerve head OCT on the Zeiss. Cirrus is normal, so she's got slightly larger than average optic nerve head size, but look at her cup, 0.05 in both eyes. So she's got a slightly larger than normal optic nerve head size, but a very small optic nerve head cup, but she's not swollen. She's at 109 in the right and 98 in the left eye. Her nerve fiber layer is not swollen, but she has minimal cup. So I always ask her, what's your diagnosis? Does she just have subjective complaints? We've all had patients that have subjective complaints. Yeah, it's blurry. I can't see it on my periphery. It's double. They've got all these subjective complaints, and you can't see anything. Is this subjective complaint in hyperopia? Is it optic nerve head drusen, or is this something pathologic, a tumor? And I remember talking to Dr. Ken. He emailed me this case about 6 months ago or 9 months ago, sometime in 2014. I remember saying, she's got elevated optic nerves. You look at her OCT, and it's not swollen. There's no swelling of the nerve fiber layer, but she's got a large disc with minimal cup. This screams optic nerve head drusen, especially when you consider her history. She's probably had drusen sitting there for 58 years. And I told him, and that's what usually the response I get. When I was in Orlando a couple of nights ago, 60% said B, and I had about 20% saying A and 20% saying C. We were spread across the board. I told Dr. Ken, I said, I think it's drusen, but she's got a subjective complaint of blurry vision in the left eye. You add to that, she's got a subjective complaint of peripheral. She says, I can't see as well out of my side vision in my left eye. That's pretty sensitive that she just told you. And you look at her visual field, and it's worse in the left eye compared to the right eye. So I told Dr. Ken, I said, because of those, it's probably going to come back normal, but I think it's worth your time to go ahead and do a VEP. See what it looks like. So let's assess the pathway right side and left side. That was her VEP. And you look at it, and sure enough, right eye looks great. Amplitudes are in the green. Latencies are in the green. We're at 107. High contrast, right eye 116, low contrast. Those are all right smack dab in the middle. Right eye is perfectly normal. And then you go to the left eye, and sure enough, your latency, both the high contrast and the low contrast are delayed. It's flagging those. And that's what's interesting about this and why this is such a wonderful test. Glaucoma is about the low contrast. I think we've highlighted that a lot. Magno, 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 low contrast. But other optic neuropathies, like optic neuritis, like nutritional optic neuropathy, ischemic optic neuropathies, or potentially a compressive optic neuropathy from a brain tumor, they're not going to be as selective. Parvo and magno, they tend to hit both. And sure enough, in this case, you certainly have that left eye being hit on both latencies, high contrast and low contrast. Could this be from drusen? Certainly could. Drusen have been shown to affect VEPs, but her drusen were very symmetrical on the OCT and on the fundus exam, and this certainly is asymmetrical. So again, Ken and I consulted and I said, you know, why don't we send her for neuroimaging? It's not going to hurt because we've got this delay. Is there anything going on? And she had an MRI that indicated she had a left sphenoid end plaque meningioma that involves portions of the cavernous sinus and does involve some of the left optic canal. VEP is an incredibly powerful tool. It's not specific, meaning I can't show you this VEP and it tells you where the problem is, but when you add it to the case history and the other findings and the fundus exam, this left problem picks up a very sensitive, we sent her for an MRI and she had a brain tumor. Fortunately, it was benign, did not require surgery, but we've got an explanation for what's going on now. VEP is an incredibly powerful tool. Diagnosis codes, these are some of our most common diagnosis codes. You'll see a lot of glaucoma there because we do a lot of glaucoma. The VEP and the pattern ERG, we do both. So 377, 368, 365. One that I do a lot as well is V58.69, high-risk medications for Plaquenil. We filter almost all of our high-risk Plaquenil patients, meaning once they've got over 1,000 grams total cumulative dose, they come through our electrophysiology clinic, and they get OCTs to look at structure, and they get ERGs to look at function as well. There's your form by Diopsys that links, tells you all the different codes. On the back side, which I don't have a picture, but on the back side of this picture, it tells what the VEP and ERG reimburse in all the different states. So in Oklahoma, the VEP reimburses about $118 for the 95930. That is the VEP. There are no frequency limitations, meaning you could do this as many times as you want. I would recommend judicious use of this, meaning don't do this 8 times a year, but once or twice, you certainly will get paid for it. It is not mutually exclusive with anything else, meaning you can bill VEP, ERG, and OCT on the same day, and we do this, and we get paid for all three, about $118 for the VEP. The ERG actually pays a little bit more. The ERG pays about $142, $143 in Oklahoma. Again, this varies state by state. So 92275, pattern ERG, pays about $142. Again, there's no frequency limitations. Be judicious, once, twice a year, once every other hour, depending on the patient, and it's not mutually exclusive. Again, you can bill ERG and get paid $142, and then you bill VEP and OCT as well, and you can bill all three and get paid for them. Again, biggest indications for the VEP, remember glaucoma, not your end-stage glaucoma, but those glaucoma patients where they could go either way. Maybe they've got mild glaucoma and you've already diagnosed them based on the nerve appearance, based on the OCT, based on the field. Let's now get some objective data. Those glaucoma suspects where you're really waffling either way. Which way is it? Is it glaucoma? Is it not? Wonderful tests. Your MS optic neuritis patients, any optic neuropathies, amblyopia, unexplained vision loss, it's a wonderful test. Visual field defects. The pattern ERG, again, I'll highlight glaucoma, Plaquenil, MAC degen. It will help to detect dysfunction in that macula, and it's a tool to educate the patient. Stop smoking. Take your vitamins. Control your diabetes. Take these eye drops for glaucoma. You may make the diagnosis based on the pattern ERG and the VEP. So with that, I believe my 45 minutes are up. Rachel, I will open it up to you for any questions.
Well, thank you, Dr. Lighthizer. That was a great webinar, and I appreciate you guys coming on for us. So at this time, we'll just leave a couple minutes for anyone to type in any questions they might have. There should be a little spot down on the webinar side if you want to enter any questions, and it will go right to both of us. And I will point out that if you do come up with any questions after we close the webinar tonight, please feel free to reach out. You can either email me or call the office, and we will go ahead and make sure that the questions are addressed if you do come up with one after we close tonight. Dr. Lighthizer, it does look like people might not have questions at this moment. So if there's anything else you would want to touch on, or else I'd want to say thank you for presenting it. It was a very helpful webinar, and I appreciate you taking your time to come on and present it with us.
Well, I appreciate the opportunity to talk with all of you. Rachel, thank you for organizing this. If there are no questions, I wish everybody a good evening, and thanks again.
Thank you, and you have a good night.
You too.
Bye.